Okay, good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Aaron. Aaron Shapiro, MD, MPH, EDAC, is a primary care doc focused on providing quality healthcare in underserved communities. He received his medical doctorate degree from the Alpert Medical School of Brown University and is currently completing his residency training in primary care social internal medicine at Montefiore Medical Center in the Bronx, New York. He received his Master of Public Health degree with a focus on health leadership and management from the Johns Hopkins Bloomberg School of Public Health. He strongly feels that the tools of health technology, healthcare management, and patient-centered design can be powerful tools of health justice work. He received his evidence-based design accreditation and certification, EDAC, from the Center for Health Design to create environments for healing for patients whose health systems have historically not prioritized the impact of the built environment. Now I'd like to request Aaron to begin today's session. Thank you.
Thanks so much for that introduction. So I will go ahead and bring this up. All right. So, and please let me know if you can't hear or see me. So thank you so much for having me. My name is Aaron. It's a pleasure to be here, and as a University of Maryland TERP alumnus also, it's amazing to see the work that you all have done to bring this about. I imagine it's been quite frustrating throughout COVID to not have the kind of shadowing opportunities that you've kind of been expected to have, and that I think are very valuable to know that you're going into the right field. So this seems like a wonderful opportunity that you've created for so many people. So congratulations on that. And so today we'll go ahead and I'm a primary care doctor. One update to the bio that was read is that I did finish my residency just a few weeks ago. So I am done with internal medicine residency, and I'm studying for my medical boards right now, and we'll start working as a full-time primary care doc in Washington, DC in just over a month or so now. So today we're going to talk about social and liberation medicine. I'll introduce what those are, and really I think the thing that I'm excited most to talk about is what that looks like in practice. So here we go. So I don't have any financial disclosures. And the objectives of the conversation today is I want to introduce you to these philosophies, social medicine, liberation medicine, walk you through a day in my clinic with real world examples, and introduce paths to pursuing careers in social and liberation medicine if this resonates with you. I'll welcome you to my clinic as I welcome all students that I work with in person, and I'll ask for some reading volunteers at that point. I'll introduce myself and how I arrived here. I'll introduce the kind of clinic work that I do. And then I'll solicit feedback to make sure that we're actually covering the kinds of things that you were hoping to get out of this session for those of you who are participating live. And I have a few cases that we can review together if we get there. So just some logistics things. We're functioning through Zoom right now. I understand, especially with the amount of education and everything that's been going on through Zoom for all of you, that it can be quite exhausting. So by all means, if you feel like it is better for you to turn off your camera, by all means, please feel free to. And then the chat features will be live. We have wonderful people moderating and monitoring that. So this time is yours. I'm here for you. So interrupt me if you have questions. And there will be a few times where I'll check in. So please, by all means, use that and do ask if you want me to go in a different kind of direction. So welcome to my clinic. So this is a sheet, and I'll ask the moderators if there's anyone who would like to read. I've got some chunks of this that we'll read through, but this is a sheet that I give to every single medical student that I work with. I unfortunately haven't worked with undergrads as a physician yet, but I think it'll resonate just the same. And I think this is a good way to get things started. Do we have anyone who might be able to volunteer to read?
I can read.
Thanks. Can you just say your name and then go for it?
Sure. My name is Kenan, and I am a pre-med student at the University of Houston, and I'm be graduating next year in the fall.
Congratulations, Kenan. Thanks for volunteering. Go for it.
No problem. So let me minimize this. I can barely see. There we go. Hi, my name is Aaron. Please call me Aaron, not Dr. Shapiro. I use he, him, or they, them pronouns. I hand this out because sometimes things get busy and we don't have as much time immediately upon meeting as I'd like to in order to learn about your passions, learning objectives, and how I can best support you. If we haven't made time by the end of the day to go over these things, please stop me. Patient care always comes first, but I take my responsibility as a teacher very seriously. So I hope you take advantage of the time we have together and get as much out of this as you want.
Thanks, and go ahead and one more, and then I'll ask for another reading volunteer after you're done. You're done with this slide.
Things I expect of you. Med students often see and hear things that the medical team misses. Please speak up if you have something to share. I expect closed loop communication. If there is a task you're expected to do, please ensure I know that it was done. And if it wasn't, please ask for help. I promise I care much more about the rapport you build with your patients than any medical facts. It's my job to help teach you, but also please teach me things. You are closer to textbook learning than I am and immersed more in academic discussions of social justice and healthcare. Please eat, use the bathroom, and sit as needed, even if it doesn't seem like we're making time for it. And if you get lost in the hallway or can't find me or want to chat about something months after this rotation is over, please don't hesitate to either text or call.
Thank you so much. Do we have anyone else who might want to volunteer to read the last bit?
I'll read.
Thanks. Who's just introduce yourself and then go for it.
My name is Anj Gyanin, but you can call me Angie. I'm a senior at the University of Maryland. I'm also a pre-med student, and yeah,
Awesome.
I'm a public health science major, so.
Thanks so much.
You're welcome. I hope to help create a mindful, healing environment for our patients. The first step to do that is ensuring a healthy working environment for us. Please do not hesitate to ask the same question multiple times. Please do not hesitate to ask for help. I expect you to immediately notify me of mistakes that we will all inevitably make. Please do not hesitate to update me on how I can better support you and the work you are doing. If things are going on in life outside of work and you want to talk with me about them, I'm here. If you experience racism, sexism, homophobia, transphobia, xenophobia, or abuse of any kind, please let me know if you would like me to know. This is unacceptable and I will step in for you, if you would like me to. If I perpetrate any of the above or abuse the hierarchy of this power dynamic in any way, please let me know if you feel comfortable approaching me. Otherwise, please communicate this to our attending, your rotation director, or report anonymously in the evaluation feedback. If you find any language I use outdated, inappropriate, or in any way devoid of the idealistic altruism we started medical school with, please let me know. If you identify any ways we can better dismantle the capitalistic, racist, heteropatriarchy of a healthcare system in which we work, I would love to discuss this with you in ways we can incorporate that work into how we provide care.
And then this is just kind of the, thank you so much for reading, both of you, I appreciate it. So I say, please hand the lower part of this paper back to me at some point during the first day with me. Please remind me at the beginning of your last day with me to review it with you. I'm glad we have the chance to work together and learn from each other. So that's how I, both with interns, with people I supervise, and medical students that come through my clinic, that's how we start things. And I hope that it kind of sets the precedent. I think a lot of what we talk about in the training that I've done are power dynamics and kind of how we introduce ourselves, how people come to different spaces, and the importance of grounding ourselves in those kinds of spaces. So yeah, thank you for reading those. What I'd love to do, so I then ask people to write down their top learning objectives for the time that they have with me, whether that's a morning or whether that's 3 weeks. And then I also ask if there's anything that they would like me to know about them, whether it's learning styles, other interests outside, or if they have a wedding tomorrow and just were kind of too nervous to ask to make sure that I knew because they weren't going to be here. So what I'd love is just to kind of start just for 2 minutes. I think a lot of the journey of medicine is reflecting on who we are and why we're here. So I'd love for everyone to take just a couple minutes, who you are, why there's only supposed to be one do there. Do you want to be a clinician, specifically a doctor? And if we're able to see if you can either write that in the chat if it's something you want to share. If you're a reflective writer and just want to take a minute to write to yourself, jot it down, or in a Word document, you're welcome to. If you just want to sit and reflect on it, we'll just take, about 30 seconds, 45 seconds for everyone just to write it down a little bit. If someone puts things in the chat, then I'll go ahead and read it, but no pressure to. And I won't read it out loud, I'll just read it to me. Thanks, Manahal. I'll take a few more seconds just to wrap up. And Manahal and team, if there's anyone in kind of any other chat streams, if you want to kind of write that you're happy for me to read it out loud, then lovely. Otherwise, if anyone has written anything, just I'd love to see it afterwards so I can see a bit who's here. Amazing. All right, so I'll keep going. Thank you for that. So I'll do the same. So I'll introduce myself. I think one of the most important things at this stage is to see how different people got to where we ended up. And it can seem quite intimidating. Honestly, when the kind of announcement for this was distributed, I was like, that looks a lot more official than this is going to be and than I am. So I want to kind of demystify some of those things, that at the end of degrees, we get letters at the end of our name. But this path is long and it can kind of be going in a direction that you want it to be, or in kind of a way that you circuitously get there. But I think we all take it on our own pace and we all take it in the time that we need. And so this is just kind of how I got there. So I was born and raised in Maryland. My dad's a pediatrician. His dad was an ear, nose, and throat doctor. So medicine was always kind of a conversation at our dinner table. And I grew up in a Jewish community that was very steeped in activism. So those conversations around health as social justice, health as a tool for activism were just always part of the conversations that I grew up having. Like many on this call, I went to University of Maryland College Park. I did the individual studies program. I created my own major in global health, and kind of in between high school and college and a little bit of college, I'm from the area around NIH and was lucky enough and privileged enough to be able to do a couple summers at NIH doing some wet lab research, which I had an extraordinary mentor and loved the kind of investigative parts of it, but knew very quickly that it was not for me as far as a career path. And then in the conversations around what I wanted to do moving forward, I got some really good advice from a couple different physicians when I was asking them about, hey, I'm interested in becoming a doctor. And they essentially said, hey, Aaron, there are a lot of ways to make a positive impact in the world. If there is literally anything you can do other than becoming a doctor, other than putting yourself through medical school and residency, do that instead. There are many ways to make a positive impact. And I took that advice very seriously. And in undergrad, I did an internship at the US Agency for International Development in their Bureau for Food Security. And then my first job out of college was a Global Health Corps fellowship for a nonprofit that did sustainable solutions to child malnutrition through agriculture in Rwanda. And I kind of envisioned myself as one of these people who would be doing program management for public health projects. And while I was doing that first job, a lot of the work that we did interface with clinicians. One nurse became nurse practitioner in particular, and the way he was able to interact with patients and comfort them and be with them, was be there for them, was just something I was very jealous of. That I liked the skills that I had, and they're actually skills that I came back to a little bit later, but was completely powerless in a lot of the ways that clinicians were able to care for other humans in very vulnerable times. So I went back to do a pseudo postbac at University of Maryland through their evening program. And then I went to medical school at the Alpert Medical School of Brown University in Rhode Island, which again, very, very blessed to have been able to go there, a wonderful program. And while I was there, I got exposed to some wonderful things and spent several years engaging with some amazing mentors and organizations. The most formative probably is Project Weber Renew, which is a nonprofit that provides all the health and social services to Rhode Island sex workers. Amazing people doing amazing work, and that's what exposed me to the opioid epidemic before it made headlines actually, and engaging in a lot of harm reduction tactics, a lot of real on-the-ground exposure to HIV and STI care, and generally being engaged with and gaining an immense admiration for sex workers and the work they do, and the people who are helping support in kind of the lives that we all live in different stages of our life. I also got exposed, Brown has one of the leading researchers in jail medicine, so went into the Rhode Island jail system for the first time. And one of my closest mentors was one of the doctors providing the majority of trans healthcare to Rhode Island's community of people who are of a transgender journey or gender nonconforming. And so all those experiences were super formative in the practice that I kind of realized that I wanted to develop for myself and the kinds of areas that I wanted to pursue. I am a systems thinker and would get very frustrated by the things that didn't work efficiently in systems. And so I decided to pursue master's in public health, again, kind of coming back from my initial public health roots, but I focused on that in health leadership and management. So I got that from Johns Hopkins University, which had a close relationship with their business school as well, and was able to essentially shadow the master's in health administration curriculum as much as I could. I tried as much as I could. But one of the most formative things there was there's a practicum requirement, a pseudo work experience. And I lucked out that I worked under some amazing mentorship at the Baltimore's Healthcare for the Homeless. And they have a very robust quality improvement and performance improvement department. And for those who aren't familiar, quality improvement is, I think, a very humble science. It essentially says, hey, we actually have done a lot of research to know what it is that we're supposed to be doing. So now we're going to ask the question, are we actually doing it? And if we're not, why and how do we do that better? I'm just taking a look here if this is something I need to pause for. Oh, lovely. Thanks, Mara. For example, we all know that children, it benefits children to get vaccinated. So if we look at all of the pediatricians in the clinic, we can see, hey, of the patients, how many of them are getting their childhood vaccines? And what is the national benchmark for the percentage of kids who get all of their vaccine by a certain age on a certain schedule? And then have we met it? Are we above it? Are we below it? And if we're below it, then we go and ask some questions as to why that is, so that we can say, hey, we've kind of figured out this is why this isn't happening, whether it's time or burnout or structural barriers. And then we say, hey, let's do some quick, not randomized controlled trials, but more, they're called PDSA cycles, Plan, Do, Study, Act, where you kind of do these rapid cycles of creative interventions to see if any of these things have impact on increasing those numbers. And that's one of my big passions. I love that kind of work. And so after I graduated medical school, I went back to my last year of medical school, and I went to the Bronx, to Montefiore Medical Center, which has a very unique primary care social internal medicine program, which I very much respect the leaders in the community that I was able to foster there. And I'll speak a little bit about more what that is. So I just graduated from residency a little while ago. During that time, we were what's called the COVID intern class, that our first year of residency was the year that COVID broke out. So a lot of our residency was dominated by COVID. And during that time in particular, I was very kind of intrigued by and impressed by a lot of the ways that people rapidly adapted to the special needs of COVID, particularly nursing, and how they changed rooms to decrease infection and increase care and increase visibility of pulse oximeter readings. And it got me interested about kind of how we engage in spaces in healthcare. And I started pursuing what health design looks like. And so the Center for Health Design, for those who aren't familiar, I recommend checking them out. They do some really amazing work. And so I devoted some time to get my evidence-based design accreditation and certification. So how does interior design, architecture, the built environment, usability, health technology, how does all of that and the design around it help improve the experiences that we have? And through that, I started an initiative called Differential Design that takes the principles of health technology, health management, health design, and tries to implement them as tools of health justice work. So I started doing some work at my clinic there in the South Bronx, and have expanded a little bit. And if people have questions about that, I'm happy to answer them. So that just ended a few weeks ago. And in mid-September, I'll start working at DC's largest network of federally qualified health centers. I'll be splitting my time. They have one clinic embedded in DC's largest homeless shelter. So I'll be doing working with their healthcare for the homeless program as a primary care provider now, and then splitting my other time in a regular federally qualified health center in Anacostia. So I'm looking forward to starting that. So I wanted to introduce you now just a bit to the clinical work, kind of like what that actually looks like. And it's a split between the kind of work that I've done and the work that I'll be doing. But I wanted to ground that first in, I mentioned my residency was in social medicine. And so what is this? And I took this just directly off of my residency program's website. So the roots of social medicine can be traced back to Rudolf Virchow, who stated eloquently, this is again from their website, that the physician is the natural advocate of the poor. Social medicine seeks to improve health through clinical care, community outreach, research, and advocacy. And the truth is that my program has kind of veered also along the lines of liberation medicine, even though it's not in our title. But we have a whole curriculum dedicated to liberation medicine as well, which from the website, these can be defined in many ways, but liberation medicine is the conscious and conscientious use of health to promote social justice and human dignity. It involves persons learning how to liberate themselves and to accompany others in their liberation, rather than how to liberate others. And these are the kinds of conversations that we have in my residency program. We are very much influenced and inspired by the work of the Young Lords, their takeover of Lincoln Hospital in the Bronx, the Black Panthers, and the extraordinary health advocacy and health provision care that they did. We talk a lot about anti-racism work, incarceration, decriminalization, decarceration, the medical apartheid, and the amount of racism that is embedded and integral to a lot of the medical systems that we work in. We talk a lot about how we work to dismantle the systems we're actively working in, which is a very challenging conversation that I'd love to engage many of you in at any points. And we talk a lot about the philosophies that have kind of brought about these kinds of conversations in healthcare, and then how to put them into practice. So this is what my practice looks like in geometric kind of representation. So at the bottom there's the primary care work that I do. So that's things like managing hypertension and diabetes, cancer screenings, primary mental health care, managing chronic pain, people come in for sick visits and what's going on. So that is the bulk of what I do, but then it's contextualized in other things as well. So I have a particular interest in sexual medicine, gender healthcare, reproductive healthcare, especially with the atrocious things that are happening on our federal policy and with our Supreme Court right now. I work with a lot of people around sexual pain, sexual pleasure. We do a lot of primary gyne care, which is a bit abnormal for internal medicine programs. And I've in my clinic in residency, not only do we do primary gyne, but we actually had an Nexplanon clinic, the implantable long-acting reversible contraception that usually goes in the arm. And then I sought out additional training through Planned Parenthood to do IUD insertion training and abortions, both medication and procedural abortions, which I was grateful to my program that they were actually the main program that said, hey, here's how you can pursue this additional training, and we'll very much support you and help you make time to get that kind of training done. So I do care for people who get STDs, people who are living with HIV, and then I really enjoy helping people of transgender experiences, people who are gender nonconforming, or gender non-binary, to get the kind of healthcare that they need and deserve as well. And then through the training that I've had through residency, there's some pseudo specialty and harm reduction training that I spend a lot of my time doing. So I work a lot with substance use disorders. I prescribe buprenorphine, Suboxone, which is one of the main treatments for for opioid use disorder, excuse me. But then I also work with a lot of people who use excessive cocaine, and want to talk about reducing that, who have alcohol use disorder, at various levels of wanting or not wanting to stop, tobacco use disorder. I mentioned jail medicine before. Our clinic had an embedded transitions clinic. So people would come out of jail and have an appointment with us, and we would either start them on Suboxone or make sure that their blood pressure was controlled, or that their mental health medications were stable and the right ones. My clinic also had an asylum seeker clinic. We would do a lot of, transitions clinics with a local organization that provided social services to immigrants. So for immigrants who are coming through, we would just essentially get them started with that healthcare and have a little bit of a heightened lens to the certain needs based off of what countries they were coming from. And then for asylum seekers, we were trained in affidavit writing. So we would do forensic affidavits, meaning they would come in, they would tell us their story. We would have read their legal affidavit beforehand with the partnership through their lawyer. And then we would do a mental health assessment and a physical exam to kind of talk about how those things also supported their legal affidavit that they had already stated. And those are used as evidence in court as ways to help discuss the usual histories of abuse or trauma that they experienced in different ways. How is this program funded? This is a medical residency. So just like every other medical residency, but different residencies choose to talk about different things. And this is what ours chooses to talk about. So our residents are funded just like most residents, which is usually through Medicare, Medicaid dollars. And then our funding, the additional funding, is through Montefiore's general categorical internal medicine program, and we get funding from their Department of General Internal Medicine. It's funded like every other program. Yeah, which I think is a testament to the leadership and saying, hey, this is just how we're going to do it. And then, cool, right? Yeah. So we were also trained by an extraordinary attending physician who went through our residency also in how to write ICE affidavits. So we learned a lot about the structure of ICE custody. And so there's a network. Sorry, someone's mic is on, I think. Was that a question for me? All's good. And so we get appeals through that network that gets medical records from the ICE custody facilities, and we are trained how to review those medical records and essentially use those as advocacy records to advocate for people getting released from ICE custody. So whether someone's on a hunger strike and we're starting to see electrolyte abnormalities and they're not receiving adequate medical care, or their hypertension isn't adequately cared for, or their mental health issues are being exacerbated by being in ICE custody, essentially as clinicians, we say, hey, this person needs better care than is being provided in custody, and it is used as a way to advocate for that person's release. I mentioned that I'll be doing some homeless healthcare and with the new clinic that I'll be working at. And we do some transient homeless healthcare. We don't have a dedicated homeless healthcare clinic with the program that I work through, but a lot of the people that we work with are unhoused or housing unstable. And we have some specific work around that. And I mentioned I do a lot of work with sex workers as well. And then I talked a little bit about the academic advocacy and administrative work that is constantly embedded in the work that I do. But we are an abolitionist-minded community. We do a lot of work in anti-racism work. The vast majority of us are quite anti-capitalist. and see the atrocities that capitalism has brought into healthcare, where people are caring much more about profit than they are about human dignity and human life. I really like using the tools of quality improvement as kind of more expeditious ways to kind of say, hey, how can we do this better? And then I mentioned the work that I've started kind of going into with health technology, design, user experience, and how can we create better experiences for people through all of these things, regardless of their ability to pay, regardless of how much our healthcare system has abused them and their families and their communities prior, trying to improve that. And a lot of that is advocacy for universal healthcare in some form, which we can debate for many years to come. So that is kind of the broad stroke of the kind of what my clinical practice looks like. It's very much a generalist practice. I like having many different lenses to look through, and I like being able to be there for an individual in an exam room, just talking to one person ahead of me and being able to be there. And then outside of that exam room, think about, hey, how can this be better? Like all the things that frustrate and disempower us. What are the kind of larger picture things that we can do to try to go upstream and stop these atrocities from happening as best we can during our time here? So I wanted to just take a little pause, a little check-in. And so now you kind of know who I am, you know my journey, and you know the kinds of work that I do. So I'll ask our moderators if people want to put into chats. I won't look, I'll ask the moderators to kind of take it from here. But what were you hoping to get out of this session? Is there something that you were hoping to or expecting to discuss that if we didn't cover, you would be upset or feel this wasn't a fulfilling use of time? Do you have any questions up to this point? And then the kind of what I have left from organized stuff are cases. So I prepared 2 cases. One is a kind of case to think about how we do healthcare for the homeless, the unhoused, people with unstable housing. And then another is an opioid use disorder case for a jail transition clinic, which I alluded to the clinic that we have. Or you can pick a topic from any of these beautifully colored shapes, or just ask any questions in general. So Manahil and team, I'm not going to open chats because I know that there are different ways to message you. And if people want to take like a minute and a half to write in with their questions, and then Manahil, if you want to kind of read down a bunch of different things, some ideas, and if you want to prioritize those in any way, but I'll take your direction on where to go next.
So I can start. I'm Robin. I'm a PhD student at Johns Hopkins. I work with TeleShadowing. When you're working with people who are in custody from ICE, how do you identify the patients that you need to help? Is there someone that's on site, or do you have someone that reaches out to you?
Yeah, so they, Chanel Diaz is an extraordinary physician in New York. She's the one that I mentioned who's an attending at my program and went through our residency. And she is highly tapped into the networks of advocacy in this area. I don't know the exact behind the scenes, but essentially what happens is they have a community in listserv, and that through whatever means, their legal connections and incarceration connections are flag the network and say, hey, we've got another affidavit. And so then through that system, however those are received, I apologize, I don't know the behind the scenes of it. Hopefully a physician will say, oh, I have time to do this, and they'll volunteer to take on that affidavit. And then there's direct communication with that legal team that says, hey, this is what we need it by. Can you meet this deadline? And then there's a little bit of back and forth just to make sure that everything is clear. Did that answer your question?
Yes, it did. Sorry, I was muted.
No, that's good.
So you're in primary care. Is that because you want to be a generalist? Because you mentioned that you have a lot of interest in like gynecology and.
Yeah, so I am a public health person at my core, and I think for me, I went into medicine to do public health kind of on a more intimate and individual service way. And I think that there's a lot of power that clinicians have in being able to influence spaces of public health. And I recognized that privilege and that power before I pursued medicine. And for me, I highly value my colleagues who are specialists, and am very jealous often about their ability to know so much about something specific. But for me, I really like treating, I'm a kind of, I don't know anything until I've had a piece of everything kind of person. And so through my reflection and kind of my journey in public health spaces and healthcare spaces, I knew that about myself, that I remember I did a rotation in medical school in the emergency room, and we essentially knew that a guy very likely had advanced cancer, but like they didn't have that conversation with them in the emergency room, and they had their reasons. Like, that's not what they did. He was not acutely in any stress. Like, there was nothing urgent or emergent about it, but we weren't going to do a whole cancer workup in the emergency room. Like, the answer was, hey, you really need to go back to your primary care doctor and like really talk about this. But he didn't technically have a diagnosis yet, and that like really bothered me. Again, everyone has their own specialty, but I kept coming across that in specialties, when they would focus on one thing, I was like, well, what about everything else that's going on? So for me, primary care is the space in healthcare to do that. It's the space that says like, hey, what are your priorities? What are the things that you want to bring to the table? And I try to embed that a lot in my clinical practice, which we haven't talked too much about. But there's a lot of discussion around how we decrease power dynamics in primary care, that at the end of the day, like, we are gatekeepers, and we need to really reflect on that and resonate about what that means, and how do we disempower ourselves from being gatekeepers as long as no harm is done or it's something that is illegal. But what is the reflective work that we need to do to say like, hey, like, I get it, their blood pressure has been out of control for, a long time, or they still haven't gone to go get their colorectal cancer screening, but like their pain is what's important to them. Or like, I'm not even going to talk about their, mild diabetes until we get their cocaine use under control, because like the depression behind their cocaine use is actually what's preventing them from doing anything. So like, talking about diabetes just like isn't even going to get there. And so one of my favorite things is like, in the longitudinal relationships that I'm able to build with my patients, is being able to really focus on those things that people come to the table saying, hey, this is why I'm coming to the doctor, and stabilizing those things. And then finally having that visit of being like, hey, can we talk about the colonoscopy you haven't gotten yet? Like, how do you feel about that? So for me, primary care is just kind of what makes sense to me as far as the kind of care I like providing, and where I feel my skill set can be of use. So just kind of, and for me, you mentioned Guy and Karen in particular, I think it's a injustice that internal medicine, which is supposed to be adult care and adult primary care, that we as a practice for the most part ignore that half the world's population has a vagina and has a uterus. And I think that is part of the injustice in a lot of healthcare. Just like all aspects of healthcare, there aren't enough providers. So at my clinic, for example, it was months to get an appointment with a gynecologist. And so to get that for like a routine pap smear or for vaginitis, and especially with what's happening with abortion care right now, like we need more providers who are comfortable prescribing at the very least medication abortions. And long-acting contraception, like it should not be this difficult to get an IUD. So the more people doing that in my mind, the better. And in my mind, that's within the purview, within the practice of primary care.
It's honestly so inspiring to listen to you, like just how important it is to like really see patients. And then like you've been able to give voice to so many voiceless populations through your career. Like it's just amazing.
Oh, thank you. I appreciate that. No, I'm lucky to be amongst amazing colleagues. And I always identified as someone with liberal politics, and then I showed up at my residency program and was very caught off guard by likely being the most conservative person there. I was very radicalized by that community, and I'm very grateful. And I hope if this radicalizes any of you in any way, the amount of injustice and overt oppression that is advanced and profited off of by my profession is quite vast. And so especially working with people who are stigmatized and who have experienced those abuses, I think one of the other things that I like to do, and I know my limits, definitely, I know what I refer to, and when I refer, and I refer constantly because there are many things I'm not good at. But if there's something within my practice that I theoretically could prevent a referral, an unnecessary referral, or increase stigmatization, or being dead named or the wrong pronouns being used, or kind of any way to or even just like it's difficult to build rapport with a provider. So any ways that I can try to expand and kind of use my degree and my training to the fullest is something that I kind of value as well. But no, I think what's nice is that there are a lot of people doing this work in very, very brilliant ways. And I hope you find more of them.
You mentioned federally qualified healthcare centers. Can you explain a little more about what that means and what that means for the patient populations?
Yeah, so a federally qualified health center is a kind of clinic that is designated by the federal government. And generally, it allows them a slightly different reimbursement and funding stream and access to, especially after the Affordable Care Act was passed, access to different kinds of funding based off of the work that they do and the populations that they provide care to. So healthcare for the homeless, for example, is a designation. It's a specific kind of federally qualified health center for clinics that provide a certain percentage of care to people who have housing instability. And so each federally qualified health center is designated each year a HPSA score, a health professional shortage area score, which essentially the federal government says, like, what's the chance that a doctor is going to want to work here? And let's combine that with like how many people actually need care by that kind of doctor. And they give a score for mental health, for primary care, for dentistry. And it's essentially kind of the federal government's way to subsidize these kinds of clinics that provide care to patients with, I don't like this term, but they say a poor payer mix, meaning patients who primarily receive their healthcare reimbursement payment through Medicare and Medicaid services. So kind of saying, hey, you're not going to get these private sector reimbursement dollars. We don't want you to fold because you're actually willing to do this care, which the private sector isn't willing to do. And so that's like, they're all across the country. It's just the kind of technical term for the kind of low-income clinics that we provide in this country. Does that answer the question?
Yes, it does. Do you see yourself implementing your experience in differential design at this health center that you'll be working at now?
Yeah, no, I think one of the things that one thing is that I'm not really good at working for people that I don't, let's see, how do I phrase this? I'll put it into the affirmative. I deeply respect the leadership of the organization that I'll be working for. And they've already done some really cool, innovative stuff. And when I've talked with architects, interior designers in DC in healthcare spaces, they've already worked a lot with the clinic that I'll be working for. And I've already even kind of through my interview process talked about some of the opportunity for quality improvement, and all of these things are kind of embed themselves very seamlessly in the work that I enjoy doing. Because I don't think they're necessarily divorceable. That if we're talking about providing care with dignity, if someone's walking into a clinic and it's ugly and dirty and the staff is burnt out and there's not enough staff, like these are things that affect our experiences with healthcare, the chance that someone's going to come back, the chance that someone's going to feel seen, the chance that someone's going to feel that they can trust the people who are theoretically there to provide them care. And then behind the scenes, making sure that we have good I really respect the place that I'll be working so that the management actually is able to provide that kind of support to the clinical care, to the clinical care workers. All of that stuff to me is one and the same. So I'm looking forward to, well, I'm going to focus on being a primary care provider first, without the kind of supervision of residency. So I'll be passively doing some of that work, but probably not as aggressively as I'll hopefully be doing in the future. The focus for the next year or so is just to try to make sure that I'm a half decent clinician.
So something we sort of like to ask everyone is if you could give the students sort of the overview of what you do day to day, and then what your work-life balance is like, or do you even have one as a resident?
For work-life balance, let's start there. I think that it's important to be aggressive about self-care because people won't carve that out for you. And residency is very tough. And I think it's important to have these conversations and start building a community and a network very early on that you feel will support you and that you feel you can support. So I'm lucky through that Global Health Corps Fellowship that I mentioned. They've partnered for years with an organization called Still Harbor and now Rootwise Leadership, that they do extraordinary work working alongside people who work in public health and social justice fields to make sure that they don't burn out. And I've had my first training with them a decade ago, and still every few months see one of their spiritual directors to talk about it. It's very grounded kind of spiritual practice work. It's different for everybody, but it says like, hey, these feelings of fulfillment and purpose are profound thoughts and profound ideas, and it's important to be intentional about carving out time to think about those things. So one kind of thing, an example that I'll give that y'all are welcome to take with you is at the beginning of residency, she and I were talking about like everything gets so distracting. You get pulled in 8 million different directions. And we talked about, hey, maybe one of the things that might be helpful for me is a mantra. Like, how do I pull myself back in and be mindful about the care that I provide? And so what we ultimately did is I ended up developing a mantra that I could create into a password. So every time I logged into a computer, it was that mantra. And each year of residency, I switched kind of what that password was and what that intention for the year was. So the first one was kind of thinking about just being mindful, the patient in front of me, not getting distracted by everything else. And this last year with the burnout and fatigue, it was talking about like the inspiration and kind of returning to what kind of doctor I want to be and the kind of care I want to provide. And then kind of making sure that I'm able to bring that in to the work that I do. And a lot of the work that Still Harbor did and does was around community building. And so I'm very lucky that we kind of talk about it as if like, oh, just find people to support you, but like you need to be intentional about that. That's not an easy thing to do. And so having those skills to know how to ask for help, know the things that I need to prioritize during times of transition, during times of depression, especially those of us who worked through COVID in the ways that we did. I think the majority of us sought professional therapy, and many of us started on antidepressants. There is a higher rate of suicidal ideation and suicide amongst clinicians, amongst doctors, than in kind of professionals of kind of similar training. And it's important to be transparent about that and be aware of it and be there for each other and make sure that we are aggressive about saying like, hey, I get it, I'm an intern and like everything intimidates me and everything scares me, but like I am going to go to therapy and I'm going to make sure that I can pick up my prescriptions on time, and screw anyone who makes me feel like that's not okay, and learning how to be really, really aggressive about prioritizing ourselves and our self-care. So that's kind of one thing. Then the day-to-day and kind of like how that all feeds into work-life balance. The life of a resident is there's no day that is the same as the last. And so even though my residency was in primary care, especially intern year, a lot of our time was also in the hospital. So that could be a night shift, it could be a 24-hour shift, which I think are inhumane and should not exist in medicine. And there's a lot of advocacy around stopping 24-hour shifts. I do not think that they should exist. I think they're dangerous and harmful, both to us and our patients. And then I'd have my time in the clinic where I'd wake up and hop on the commuter rail and go down to my clinic in the South Bronx and see my patients. And towards third year, at the end of third year, I was seeing, I think, maximum 8 patients per half day. So that's approaching, but still not quite the amount that an attending sees. And then in residency, you also have didactics, you have learning, which for us was a lot through Zoom. And then, yeah, I think it's challenging during medical school, I was pretty good about making sure I had a good work-life balance. I think at any stage we can tell ourselves that we're not doing enough, or any stage we can tell ourselves like, I should be doing more. This is a long journey. And I think especially, you know, if you're still in college or if you're doing a gap year or, you know, pursuing more time away and debating whether or not you want to go to medical school or initially are eventually are in medical school, like that is important. Those are important habits to develop early, because as time gets less our own, and we're able to control things less, it's important to have really practiced how to do those things. So like cooking was a big thing for me. Like I can now cook a like full meal in 30 minutes, like a nutritious home cooked meal in 30 minutes, done. But like when I first started cooking, it took me a lot longer. And so to start when, even though it doesn't seem like you have enough time, like you do, I promise you always have enough time, but it's important to like start building those habits now so that you can prioritize the things that make you happy and bring you joy and fill up your cup throughout the rest of your training and beyond. Did that answer your question? Did I miss anything?
Yes, it did. No, thank you so much. Yeah, thank you for taking the time to answer all of my questions. Feel free to continue with the session now.
Oh, cool. So that's my cue to keep going with cases, or were there any other? Oh, lovely. Sorry. Maybe other people had some to chime in on, but great, lovely. So, and then were there any kinds of things other than these two cases that I mentioned here? Were there any other kind of cases that people wanted to talk about? Any thoughts of which one? Well, we'll just start with number one. All right. So cases. So this is a 39-year-old female with diabetes living in a homeless shelter. So the case is a 39-year-old female with a history of type 2 diabetes. Her last hemoglobin A1C was 12. I'm not going to get into like the details of these things. These are things you do not need to know or learn, but 12 is high. It's far from the highest I've ever seen, but it is well out of goal. Hemoglobin A1C is the measure of sugar, of glucose over averaged about over 3 months. So it gives us a good sense, not just a finger stick of what your sugar is, but like how have people been doing over the past 3 months. So she's presenting for elevated blood pressure, which we got on regular vital exams at the last visit, and management of her diabetes. So the medication she's on, she's been on metformin, which is an oral medication to treat diabetes, a multivitamin. And then at the last visit, there was a discussion and we started her on a kind of insulin that you inject 2 times a day. She also received some diet counseling at the last visit. So when she comes in, the subjective thing that she says, what she shares, is that she administered insulin at night, but wasn't able to access her insulin during the day. And then 2 days ago, her insulin needles were actually stolen, so she hasn't injected since. She hasn't been able to make any changes to her diet. Her vital signs, she doesn't have a fever. Her heart rate was 80, which is perfectly fine. Her blood pressure is 160/90, which is in the higher range. Again, hardly the highest I've ever seen, but it's in the range of something that we say, hey, this is too high. And one thing with blood pressure management is we never go off of one reading. And we won't get into this, but there are other ways to actually diagnose hypertension. For the sake of this case, we'll say that, hey, this is good enough where we say, hey, we want to kind of talk about your blood pressure. This isn't just a random thing. This is something that we should actually talk about whether or not we want to treat it. Her physical exam is unremarkable for the purpose of this case. So the kinds of questions that I have, and please feel free to put this in the chat or just reflect to yourself. I'll pause for a minute afterwards to see if people have any thoughts. But the kinds of questions that we want to bring are, how do we better help her manage her diabetes? What do we think about her blood pressure treatment? I gave you a little bit of a clue already. And then what do we think about her diet counseling? What can we do outside of the clinic visit once she's gone to help with others with these kinds of challenges? So this case essentially is getting at 2 bread and butter topics in internal medicine, which is hypertension, high blood pressure, and type 2 diabetes. And then starting to think about, hey, how does care for people with these 2 conditions, what are the kinds of special things we need to think about with someone who is living in a homeless shelter? So I'll pause and Robin or Manahil or however anyone wants to do this, whether people want to unmute with any of these thoughts, or if you want to read things off, I'll take your direction.
Okay, so I guess I could read out some of the things that people are saying in the chat.
Thanks, Amanda.
So first off, we have, would weight loss or weight management help via diet counseling?
Cool. So yeah, I didn't give a BMI. Also intentionally, BMI is a racist index. We use it as a easy way to talk about weight, but it is steeped in racism. And so it's something that, other than if I need to get insurance to cover someone's bariatric surgery, it's something I don't use or bring up. And if this person was overweight, then that's one of the things we could talk about. Weight loss is also very much steeped psychologically in how our capitalist system demeans and ostracizes people who are quote unquote overweight. So when talking about weight loss, that can be a whole kind of discussion in and of itself. But if we get to a point where we say, hey, one of the things that can help in decreasing diabetes and decreasing hypertension is absolutely decreasing weight. That is a conversation that we come to. With diet counseling, the piece that I was hoping to kind of bring up with that, and I'm glad you prompted me for it, is that a lot of the patients that I work with live in food deserts that, through redlining, through racist, both local and federal policies, a lot of the people I work with live in areas of imposed poverty where it is not easy to get nutritious food. So we can say, hey, one of the best things to decrease cholesterol or decrease or lower weight is transitioning a diet towards a whole food plant-based diet, a vegan diet. Hey, go to the grocery store instead of KFC, and all of these things have financial impacts. And one of the things that lessons that I learned from Healthcare for the Homeless when I worked with them, a very innovative organization, is that a lot of the people who they work with get their food from food shelters, from food pantries, and soup kitchens. And so we could say, like, hey, change your diet, but like, they don't go shopping at a soup kitchen. They just take the meal that they want. So one of the innovative solutions that they had was they actually then went to the food pantries and went to the soup kitchens and said, hey, like, can we talk to you guys about the kinds of food that you're offering, to not only help this one patient, but to help everyone kind of in that area who went to that soup kitchen for food. So great question with kind of weight loss, diet, all those kinds of things. What other thoughts do we have or questions?
Yeah, so we have some more thoughts about food access here.
Awesome.
Someone's saying, I think that clinics should also form partnerships with food agencies to help give access to better food choices. And someone else is saying, I think that since she lives in a homeless shelter, finding healthy food options that have longer shelf life, such as canned fruit and vegetables. Also, the doctor should consider, if she lives in a food desert, to access easier ways to find healthier food.
Love it. We're all on the same page. Great job, guys.
Is her insulin only available at night because it's stored at the shelter?
Great point to pick up on. So yeah, so a lot of homeless shelters are structured that they're places of sleeping, but they're not day programs, a lot of them. So if that doctor or I prescribed insulin 2 times a day or 4 times a day, where is that insulin being stored? How are they accessing it? Where are the needles being stored? How are they accessing it? And so that was a great, perfect thing to pick up on. And was the point of that is that medicine doesn't stop with the prescription pad. Like, our prescription is only as good as people using it. So if the decision, so first of all, there are a lot of other medications, oral medications, that we can use to help people bring down or improve their glucose control. So that's one thing to consider. There are a lot of really interesting things to think about with medication management for housing unstable patients. Blood pressure medications, for example. I'll kind of dive into that so that we can also move on to the next case. Is that there are these wonderful guidelines about what medications we use to treat blood pressure, and based off of whether someone has diabetes or kidney disease, which blood pressure agent do we start with? And when working with populations people who are unhoused or have housing instability, we actually often veer from those guidelines because some of those medications make you urinate a lot. And so if someone needs to urinate a lot or needs access to a bathroom more than they did before, that might deter them from taking that medication. The other thing is a lot of those medications you need to follow up with labs, that you could have some very dangerous changes in potassium, for example, with some of these medications. And if I'm not 100% sure that this person's going to come back for regular labs, or that, I don't know what other medications or substances that they're taking that might change some of those balances as well, I might go for a different medication that I don't need to check labs for. So insulin is another one of those things where we need to think not only about, hey, this is what I would prescribe in general, but it's all patient-centered. It's all about kind of who is the person in front of me and what are their specific challenges with their healthcare journey. And if they come back and say this isn't going to work at all, then we revisit and we troubleshoot. And we don't necessarily throw it all out, but we ask those questions. And one of my least favorite phrases in all of medicine, which you will hear time and time again, is patient is having a heart failure exacerbation due to non-compliance. Or patient's diabetes out of control due to non-compliance. This notion of non-compliance is this person is not doing what we told them to do. It's their fault. And that is steeped in so much problematic language and philosophies around the power dynamics of healthcare that, again, we can talk hours about for. But the idea is, if you say, hey, their blood pressure is out of control because they're not taking their blood pressure medications, non-compliance, what is the differential for that? So a differential diagnosis is someone comes in with cough, we ask more questions. Is it because they have seasonal allergies? Is it because they have gastric reflux? Is it because they have the flu? So if someone's coming in with high blood pressure because they're not taking their blood pressure medications, is it because they can't afford their blood pressure medications? Is it because the blood pressure medication has a side effect that they can't tolerate? Is it because they also have mild cognitive impairment, dementia, where they're really good at compensating and no one's picked up on the fact that they've been saying that they're taking their medication, but they're not? There's this huge broad differential, this discussion around figuring out the why and the how that are super important to be able to create a non-judgmental environment in a consultation in the office, to be able to actually say oh, I prescribed this medication and you're not taking it. Well, there's nothing else I can do. There's so much more that can be done. So cool. Are there any other burning questions about this case, or should we move on to the next one?
I think you can go ahead and move on.
Cool. So this is a post-release from incarceration visit, and I'll give a little bit of context that historically and currently, so our incarceral system, our quote-unquote justice system, is also very steeped in racism. It is a system that was birthed after Jim Crow laws, and when white supremacists in the United States could no longer legally enslave Black people in the United States. This was the next iteration of how white people can control Black bodies. And so there is a lot of work in the communities I engage in around kind of how do we dismantle these incarceral systems. And while we're doing that, they still exist. So again, that theme of how do we dismantle the systems that we're actively working in. And so one of the things that has come out of the healthcare work in the incarceral system and around the incarceral system has really come from opioid use disorders. And I'm very lucky that one of my mentors at Brown during medical school was the main physician who did this extraordinary groundbreaking research that showed that the majority of opioid overdoses were coming, I think it was within a week, 2 weeks of people being released from incarceral settings. And the reason is because they were forced to detox from opioids in jail. They came out, saw their drug dealer, shot up at the same dose, and immediately died, because we lose the tolerance to opioids through the mu receptors that build up in our brain with when we detox like that. So he's done amazing work, and other providers around the country have done amazing work, and around the world, and Scandinavia have done amazing work around the importance of medication-assisted treatment for opioid use disorder. The names you'll hear are most commonly Suboxone, buprenorphine, and methadone. And if people have questions about those, I'm happy to talk about them. But as a result, it is essentially medical malpractice not to offer one or both of these medications in a jail system. And it's become more common to offer these medications in jail. And the idea is then that still there's that concern that people come out of incarcerated settings and are high risk for being targeted by drug dealers who are waiting to give someone a free bag as a gift coming out of jail. And there's high risk of overdose or depression or re-engagement with abusive or oppressive people in their lives that are triggers. And the idea is to get people into healthcare, which then streamlines them into social services as well, as quickly as possible. So that's some context. Really great programs that have popped up around the country doing this kind of work. So the case is a 44-year-old male presenting the day after release from jail for a transition visit. Last seen in our clinic a year and a half ago by a provider who's since retired. And before the visit, while the patient's waiting in the waiting room, they did a quick chart review that showed treatment for opioid use disorder with buprenorphine, the medication I mentioned, active alcohol and cocaine use at the time, and then treatment for anxiety with benzodiazepines. And so a patient comes in and the subjective, the things that he offered up, overall glad that he's finally released and feels good. He reports pain from an exacerbation from an injury that he had years ago. He wants to get back on Suboxone and his benzodiazepines. He reports that he was forced to detox from opioids in jail, but he was continued on his benzodiazepines through jail. He reports that his last heroin use was last night, and his last cocaine use was this morning. He reports no alcohol use since before incarceration. And one thing I want to point out about the way that I write subjective parts of the medical history, and you'll learn this, so I'm indoctrinating you early on, take it or leave it, one person's opinion. Whenever I document histories from patients, I write everything in the affirmative. It's one way that I've worked to try to eliminate some of my own implicit bias in how I hear people talk and how I then document it. The medical record is very powerful. More common language that you'll see is denies alcohol use, which I think has very judgmental connotation. It essentially says, they said that they're not using alcohol, but are they? And so whether it's fevers, chills, or whether it's sex outside of a monogamous relationship or anything, or heroin use, cocaine use, everything for me is in the affirmative. They report heroin use, they report no alcohol use. Vital signs, no fever, heart rate 95, on the touch of a little bit of a fast heart rate. And then blood pressure 130/80, a little bit high, but pretty darn normal. The relevant physical exam is that his pupils are small and symmetric, and that the COWS, which is a subjective questionnaire that we do to measure withdrawal from opioids. There are a bunch of these different kind of calculators and questionnaires that we use throughout medicine. So I just wanted to expose you to the concept of one. Their COWS is 3. What this scale essentially does is it tries to say how much is someone in withdrawal from opioids. And essentially, you can cut off at different points, but essentially above 10 is like, oh, they're definitely in withdrawal right now. So this is saying, well, I'll ask if anyone, the first question I'll ask is, like, do people understand what small pupils and a COWS of 3, if anyone happens to know what that is? I'd love to hear from you, and if not, I'll gladly share. And so here's the question. So what testing do we order? Do we start him back on buprenorphine, Suboxone? Do we start him back on benzodiazepines? Again, there are power dynamics, real power dynamics. At the end of the day, like, do I prescribe it or don't I? How do we co-manage the pain that he mentioned? And what advocacy initiatives can we engage in to help others facing these challenges? So I'll pause if anyone has reflections. Some of this medicine can be complex. I am simplifying a lot of it, and there are a lot of kind of questions and more things to ask. But I'd love to hear your thoughts, the questions that you have, or if you want to kind of take a shot at any of these answers about how you might approach this, or if we were talking about, if you came into the room with me and we talked to this patient and then we went out of the room, the kinds of thoughts that you would have about next steps.
So someone in the chat is saying test for a urine drug screen, blood alcohol level.
Great kind of thing to bring up. So there's a lot of discussion and debate around the value of these things. So a lot of our testing, especially around substance use, is to police. It is to say, I don't believe you. And so there are, depending on what state you're in, depending on whether or not they've been released from jail under an alternatives to reincarceration program or alternatives to incarceration program, which the government or the judge that has decided that they're not going to be in jail right now, if there's a requirement that they need to be tested, then fine. Then I'll be like, hey, like this is a requirement, like this needs to happen. But for the most part, I don't do too much testing. Blood alcohol level. So this guy has polysubstance use disorder, many different substances. And it's really important, I think, to think about, hey, let's talk about each one of them, because each one of them is different. And so is the heroin, what is the heroin used for? What kind of high is it giving? What's the purpose of it? Are you then using cocaine because the heroin got you too much into a depression and then you're suicidal and you need an immediate lift? Or are you using the cocaine because when you're having sex, the heroin's giving you a great erection, but then you can't ejaculate? So what is the reason behind all of these things? Alcohol use disorder, this person, was drinking alcohol before, said he hasn't used alcohol kind of since then. Nothing on my physical exam says that this person is drunk right now. What is the purpose of that test that I would order? Most of the time when I offer or advise or recommend a urine drug screen to someone, there's a lot of fentanyl, which is a very, very heavy duty opioid in a lot of drugs now, especially cocaine. And so a lot of my patients actually want their urine tested for fentanyl to see if their supply of heroin or their supply of cocaine is laced with it, to see whether or not like the drugs that they're getting have things in it that they didn't think about. Or sometimes we'll talk about it and be like, hey, like I actually haven't had a benzo in a while. And then I'll be like, hey, like I have a question, like actually benzo showed up in your urine, what's that? And it'll be like, yep, nope, I did. I still had a clonazepam left over and I was really anxious the night before. You're absolutely right. Sorry about that, doc. Or they'll be like, I genuinely have no idea where that came from. Like maybe I got way too, messed up the other night. And like, that's kind of scary to me that like I took a drug that I didn't know that I was going to take. So I like to use these tests as tools of empowerment to say like, hey, you're in my office. You came to my office, unless it was like court ordered. Which there's still strategies around harm reduction and engagement and motivational interviewing to talk about those kinds of things that I do a lot to try not to police and kind of like say, hey, like this is what's going on. There are certain times when I'll talk about that as openly as I can with the patient. But for the most part, I use these tests as tools of safety. So if the other reason to kind of start doing one of these drug tests is that with buprenorphine, I won't go into like all the specifics of it. You'll have plenty of time to learn it. But buprenorphine specifically, you need to be in withdrawal or no opioid in your system to start it. Because what buprenorphine does is if you're at a COWS of 3, if you still have that heroin in your system, or you were given methadone and you want to transition from methadone to Suboxone, and again, there are like different strategies for it, but the base of it is that like there's this high risk that I'm going to precipitate withdrawal, that Suboxone that I'm prescribing is going to push the heroin off the mu receptor and make them feel miserable, like absolutely miserable. And then that's such a terrible experience that they're never going to come back to Suboxone. And this amazing drug that could really help someone, they've completely turned off to it. So that kind of conversation I'll have, and I'll be like, hey, like, oh, your heroin was like 2 nights ago, like 3 nights ago, or like, how do you feel about getting this test just to like confirm that there's no heroin in your system if your COWS is 0, but like I'm not sure if you're like on heroin and like completely, at a functional level, or if you haven't had heroin in like 5 days and like we want to solidify it. That's a conversation I'll have with people together. So really great instinct as to kind of like what we've been taught as to what needs to happen in order for us to prescribe certain things. And it's something that a lot of us have been really trying to challenge and flip on its head, that a lot of these restrictions and barriers, I needed to pay hundreds of dollars to be able to prescribe Suboxone to a bunch of people. I do not need additional certification to prescribe oxycodone. So there's a lot of racism in the history of methadone versus Suboxone. Methadone you need to get from a program in a clinic historically came around when opioid overdose was particularly dominating Black communities. And when the opioid crisis became a crisis that affected suburban white people, all of a sudden they were like, let's deregulate this. Let's make Suboxone more available. A primary care provider can prescribe it. So there's a lot of policing and racism in our protocols, our standard operating procedures for a lot of the treatment that we do around substance use disorders. And I think having those conversations and thinking about like, why am I doing this? What is the benefit of the patient? And if I create something or turn them off right away and they don't come back, like, are they just going to buy it on the street? And there are a lot of nuanced conversations to have about that we won't get into now, but just wanted to introduce that. So that was a long answer to a great comment to bring up. What other questions or comments about this case were there?
Yeah, so we have some comments about the COWS score and the pupils. So people are saying a COWS of 3 is a low withdrawal score, ? And then the small pupils means that the pupils might be constricted due to narcotic use.
Great, exactly. So, and we can have these conversations. So a patient might come in and say like, hey doc, I'm feeling great. Like, I'm pretty sure all that heroin's out of my system. And I can say like, well, based off of the time course of the heroin use, like maybe what's happening is like the cocaine is actually kicking in a little bit. And so there's this kind of really interesting dance that we need to have around, is this person solid? Like, did they just shoot up and they're actually feeling great? Or are they in withdrawal, but on another substance that's augmenting kind of what I'm seeing and how they're feeling? And these are all just like really interesting, fruitful conversations to have in the office at that time to say like, hey, now we have this, like, what's the next step moving forward? And we're both on the same page about what that is.
And I actually had another question about, like, what are the implications of combining having the benzodiazepine medicine and the buprenorphine? Like, at the same time, would that cause some serious side effects or maybe like amplify side effects in any way?
Great question. So buprenorphine and benzodiazepines, that's like your clonazepam, like all those kinds of your Klonopin, like those kinds of Valium, those medications. They can be prescribed together. The important point that I'm glad you brought up the benzodiazepines is that benzodiazepines used to be used a lot for anxiety, and they work well in the immediate. And similar to how we've like moved away from prescribing oxycodone for pain, like we have definitely moved away from prescribing benzodiazepines for anxiety. They work similarly in our brain like alcohol does. So like that's a conversation I definitely want to have. And then also you can overdose on them as well and withdraw from benzodiazepines. So there are because of a lot of these initiatives to decrease prescribing of oxycodone, of opioids and benzodiazepines, one of the things that's really important to think about is doing all those things safely. So if he's saying, one of the things that I kind of didn't put in intentionally was that like I don't have records from the jail system, which is a very common thing. And so there can be this discussion. People think very black and white about some of these decisions. Like, I am going to be one of those providers who continues this person's abuse of benzodiazepines and I will not be part of it. Or kind of like thinking a little bit more nuanced and saying like, well, what if like there are certain things that we do and I can prescribe like a week, couple days worth, and I see them like in 2 days again, and we talk more and build that rapport, and then I see them again 3 days later, and then I see them again a week later, and talk about like, then build rapport and say, well, what was the benzodiazepine initially for? Oh, anxiety, we actually have better medications for that now, and I'm also going to connect you to our behavioral therapist, and like, how do you feel about finally talking about some of the issues that like you were prescribed these benzodiazepines for? Because if he has been taking all these benzodiazepines for this amount of time while in jail, and he's got his appointment with me expecting that that prescription is going to be continued, either that's going to be bought off the street, and we don't know what's in that medication, and it might be laced with fentanyl, and he might be dead tomorrow, or he might withdraw and have a seizure or die from withdrawal from benzodiazepines. So the point of bringing that in and all of these things is you can see very quickly, like this is a case of mine. Like this is not uncommon for me. And the main things that I take away from these interactions is that this shouldn't be putative. It shouldn't be policing. And there's a lot of nuance into the opportunities and potential for long-term building relationships with people with polysubstance use. And then there's a whole other conversation about like, I have one time felt like, ooh, is this person manipulating me? Like, is this person like, really, am I too naive about this? But also with the work that I did with Project Weber Renew, I had some beautifully frank conversations about kind of like how to engage with people who are trying to get my prescription pad. But for the most part, like that is far from the norm. It can be that when people don't feel listened to or heard, and they're like, well, I'm not actually going to trust this person or engage with this person. Like, oh, I just don't want to be in pain, or I just don't want to have this anxiety, or I don't want to remember the trauma that I experienced. But the hope is that we actually build meaningful relationships and build trust and build rapport where that conversation can be opened up and there can be more meaningful relationships that include prescribing. Any other questions about this case or thoughts?
I actually think the benzo issue is like pretty fascinating. I used to work in a toxicology lab, and pretty much everyone that was abusing drugs was also taking a benzo to deal with like side effects of withdrawal between drugs.
Yeah.
And there's a lot of like literature coming out that's saying that like the more you take a benzo, the more it exacerbates. Like you have anxiety and you take a benzo for a lot of time, and then your anxiety is worse. You need the benzo more.
Yeah, benzo
how
scare
do you,
me.
yeah, how do
Sorry,
you
go ahead.
break that toxic cycle in someone?
Relationship. So the patient that I'm thinking about was on 120 pills of clonazepam a month, like low dose, but he was like using it interchangeably. And there was question about whether or not he was taking it. And during COVID, we all stopped seeing patients. And so the provider that I inherited from did the right thing and like wasn't bringing this patient in, but was refilling. And then the patient got used to just refills. And it was a very, very challenging case. And we built rapport and we managed pain, and I didn't cut him off. And what we eventually decided on is that each month we decreased that prescription by 10. And he got into some behavioral counseling, and we had contingency plans. So like everyone misses an appointment, everyone oversleeps, everyone like anxiety gets the best of us and we don't show up. But like what I very early on is like, I don't want to be questioning this each time. Like I don't want us to be going through this each time where it's like you missed your appointment and then that puts a burden on my administrative staff. Like we will do our best, but like this is how this works. And so we had contingency plans, like if an appointment is missed and you can get 5 days worth of pills, but like there needs to be an appointment scheduled. If you don't have that appointment scheduled within those 5 days, then like we're not prescribing another medication. And like if you want to come back, then you come back when the next appointment's available. So there were honest and like reasonable contingencies built in. It wasn't like you don't show up and then you're kicked out of the practice, which used to be a lot of these substance use programs, is that like 3 strikes and you're out kind of vibe. And that's very much out of fashion now because people realize that's just harmful. And so there's a lot of nuance and it's not like I do that for every patient. Like this is what I came to with this person in front of me. And we talked about trauma, and we talked about anxiety, and we talked about kind of relationship and job and all these other things that impact this person's life. So no, it's challenging. Benzos scare me. There are certain drugs that if people come in, I'm like, nice. Like people comes in with like cannabis, I'm like, I recommend that you don't, smoke it. I recommend that you eat your cannabis. but then there are other drugs that come in and I'm like, hey, I get it. Like, let's talk about harm reduction and like making sure that this is as safe as it can be. But like, it makes me nervous that you're on this. I'm genuinely concerned about your safety. But it comes from a genuine place, not a place where it's like all drugs are bad. And I think people get that about me pretty quickly.
It seems like these kinds of counseling conversations would take a lot of time. How do you balance that with your pressure to like get through your schedule?
I'll see more when I'm a kind of full-time doc. I think that a lot of practice, and I mean, like, these are skills that you build. And things can be really frustrating for people. And I theoretically should have a lot more time to do things, but it can be done. And there's a lot of training, hopefully, that you'll get around agenda setting and motivational interviewing and rapport building. I don't think I have like a straightforward answer other than like it's skill. Like, some people are really good at putting central lines in. I'm not one of those people. Some people are really good at having motivational interviewing conversations with a harm reduction flair. Other people aren't. And that's part of why we choose the specialties that we go into.
I think the last question that somebody sent in was, how long does opiate withdrawal last?
It's a great question, and it's something that I will gladly answer offline. I kind of want to avoid some of the more medical aspects of these things. And it's depending on the drug and other drugs that are, and their kidney function, like there are a whole bunch of things that go into it. And it's a lovely medical question that I'll gladly chat more about offline with. If that's okay, I apologize.
No, that's totally fine. Feel free to continue.
Cool. So literally next step. So I hope that I radicalized you a little bit. I hope I recruited you a little bit. Primary care is wonderful. I think it's a very valuable thing to go into. And especially with the Affordable Care Act, we're paid more than people traditionally thought that we were. And I think people are getting better at providing better work-life balance for primary care doctors, because a lot of people realized that it was just unsustainable. So I hope you seriously consider the profession. I love it. And just some kind of unsolicited advice to kind of wrap up on, because I have the chair right now, so why not? But take it with a grain of salt. My hope is that you'll find wonderful mentors and be part of wonderful lectures and be part of a random lecture on something random and they say something profound and it sticks with you. And some of this advice comes from exactly those kinds of things. So I just encourage you to reflect on why you want to be a doctor and do it again and again and again and again and again. Prioritize the things that bring you joy, make time for them. Find mentors and kind of ask them all the kinds of questions that you've asked me and continue to ask them as you go forward. There are mentors that I made in college at University of Maryland that I still reach out to. Take your time. You are not behind. You are going at the correct pace. I don't necessarily like the term gap year because I think it puts a finite like time on a break. I think everything should be done in the now with exploration of your passions and needs in the moment. And I'm a huge believer that if we become really good at like listening to that gut and reflecting, that we go on the path that will get us to where we want to be. That is a statement of immense privilege that can be unpacked in many different ways. But I think as we think about kind of, where we want to be in 10 years, it becomes much more fruitful to explore our curiosities in the now, and then kind of go with those curiosities and passions, but on your own pace. And so if, instead of taking a gap year, just like pursue something. And if that turns into 2 years or 3 years, like I have friends who returned to medical school years later, and I have friends who went to medical school and during the first year of medical school or first year of residency were like, whoa, this isn't for me. I'm only realizing that now. And I really wish I had reflected more early on. So go at your own pace and follow your joy and your passion every single step. Remember all the things you didn't know before starting medical school. And I imagine that you've had different lectures, especially at this stage. I hope I did a decent job of it. It was an exercise for me as well, that our patients did not go to medical school, and it's really easy, especially when we're insecure about our own knowledge. The way that we handle being insecure about our own knowledge is trying to sound smart. And so we use big words, kind of hoping that we're gonna, shut up our patients because they won't know how to respond to it, or they'll feel stupid because they don't know the word that we just used. And it's really important to resist that. It's really important to constantly remind ourselves, what did I not know before college? What are the words that I did not learn? And in those kinds of discussions, say like, hey, if I used a word or if I said something, like, please let me know, like ask those questions, sorry, and apologize if we use words that are not normal vernacular. And not just words, but like a cough can be terrifying, and it's really easy to be like, oh, that's just a cough from gastric reflux. But we don't know the trauma people have experienced. We don't know the heart attack history that people have had, and to really kind of just like be humble about the things that we didn't know before this training so that we can bring that into our care. Remind yourself constantly that you've chosen a career path where you will never feel expert. There's always more to learn, then relearn, then learn again. I'm studying for my medical boards right now, and it is incredibly frustrating to know that I knew this better third year of medical school than I do now, certain things. But it's important to like find the excitement in that also, I think. It's frustrating though, very frustrating. Our patients have lives outside of our offices, and so it's really easy to feel frustrated or blamey when someone comes back and they're like, oh, I didn't do that diet journal that you told me to do, or I didn't have time to pick up the medication, or whatever it is. And like, they're coming to us, we're here for them. I strongly believe that healthcare is a service profession, meaning that we are there for them. And so we just keep meeting people at whatever step they're at. Modern medicine is founded in racism and classism. Again, lectures on lectures on lectures, conversations on conversations on conversations. That is the reality of it. Constantly challenge it, constantly. People are like, oh, well, that's not the way things should work, but it's what we got. Challenge it. Then what are we doing about it? Find peers you trust to continuously check you. I think that's both from a place of hoping that you find peers who will call you out if you say something or act in a certain way, but also like who know your mood and will call you out if like, ooh, like, I think Aaron, you're drinking a little bit much this week. Like, are you concerned about that? Should I be concerned about that? But find community and friends that you can have challenging, deep conversations with, and value those people and prioritize those people, whether or not they're physically in close proximity to you. Aggressively make time for therapy and self-care. We are intentionally pursuing a career that most people never have exposure to, especially during COVID. Like the number of ribs that I've cracked doing compressions and the number of young people that I've pronounced dead way before their time is more than most doctors have done in their entire careers because of COVID. We are intentionally, and the stories and trauma and hardship that people bring into my office every day is draining. And I have invested a hell of a lot of time in making sure that I can absorb that or not absorb it in as healthy a way that I can. It is super important. Do not diminish or belittle that. That is part of your job, is caring for yourself. If you're making time to study, you make time for therapy. And then this was just one that I mentioned that I got from a previous lecture during medical school. I have no recollection of the professor and no recollection of the actual topic, but he said if a street performer gets you to stop, if you're like, oh, you're like walking by and they're singing and you stop, you owe them money. Pay them money. They're performers. That's how they're making their living. Completely irrelevant, but it stuck with me. And I said, if I were ever going to give unsolicited advice like this during a lecture, then I was going to add it on, because I think that was some of the best advice I've ever gotten. So thank you. So I'm around. I don't know if there's more time for questions or not, but I'm here. That's my Twitter and differential design. If you're curious about the kinds of things I was talking about how management, design, technology can be used as tools of advocacy and health equity. That's the kind of projects that I'm working on, and it's all open source. It's all usable by anybody. And there's actually one project, clinicky.wiki, which I hope that you all use as clinicians. It's supposed to streamline evidence-based medicine and primary care to allow you to focus more on the interactions you have with your patient by aggregating and curating the most used resources that we use in the office. So I'd love for you to share that with whatever institution you go to, and I'd love your feedback. All this is new. And then that's my email if you want to reach out about anything specific.
All right. Thank you very much, Aaron. We really appreciate you taking the time out of your day to answer our questions and taking the time to mentor all of us. I'd love everyone to please give a warm thank you to Aaron in the chat box for this incredibly informative session, as we all know that this is very helpful to all of us.
And good luck on your boards.
Thanks, I'll need it.
Now we're going to conduct our closing session with our quiz and future session dates. So the link for the quiz for this session is now live. You'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat now. And for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, July 30th at 10 a.m. Eastern Standard Time with our physician mentoring us in dermatology. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.